We'll now be demonstrating the injections of the foot and ankle. For many people, the foot and ankle are rather confusing because of the complexity of the bones and the ligamentous structures. However, if we divide the ankle into the medial, anterior, and lateral portions, it can simplify the procedure. As usual, we wish to listen to the patient's history about the complaints of pain, mechanism of injury, and what's happening with their ankle in addition to our examination. Also, our examination involves, again, careful palpation with one finger or thumb. The ligamentous attachments that we know from our study of anatomy will be prominent portions where there may be tenderness. We wish to pay particular attention to those areas of tenderness, although they may not be the exclusive domain of our injections. We start with the careful palpation and marking of our anatomy of the medial ankle. Again, it's always important to mark our anatomy so that when we palpate, we can return to those locations. We wish to mark in the position that we're going to be doing our injections so that the anatomy doesn't shift and change. We can palpate easily the medial malleolus, and we'll mark the bottom portion of that. We think about the posterior tibial talar ligament that comes from a little prominence just below the medial malleolus and comes back onto the tibia from the talus. We think then about the tibiocalcaneal ligaments, the medial portion of the deltoid ligament that comes down and attaches in this fashion from the tibia onto the calcaneus. And then the anterior portions of the deltoid ligament, the tibionavicular and the anterior tibiotalar ligament coming down onto the navicular and the tibiotalar ligament. And as usual, we can then carefully palpate and often feel little bony prominences where these ligaments attach, which will be areas of tenderness if those ligaments are involved pathologically. So careful palpation of the ligaments around that area, and then noting with our marker areas that we wish to inject with particular care. We then palpate along the distal tibia, the distal part of the malleolus, carefully all around it, again noting spots that we might wish to inject. Our next anatomical landmarks that we wish to think about on the medial angle involve the spring ligament. Part of the spring ligament externally comes from the sustentaculum tali, which, if we drop down from the medial malleolus, is a bump that has varying prominence. Sometimes you can feel it quite well, sometimes it's a bit difficult to feel. But we can feel it right here, and we'll put an X in that area. If we look at the ankle model as we do this, we can see the deltoid ligament, the posterior tibiotalar portion, the tibial calcaneal portion, and then the anterior portions with the tibionavicular and the tibiotalar portions of the deltoid ligament. And again, we've carefully palpated this entire area, marking where our painful attachments are and on the malleolus. We're now turning our attention to the spring ligament coming from the sustentaculum tali right here up to the prominence of the navicular right here. And we can see the spring ligament between those, and it's named the spring ligament for a reason, and that is that every time you step, it's what provides some of the energy to put spring in your step. We palpate that on the ankle itself by coming down from the malleolus and feeling the prominence of the sustentaculum tali, and then coming up to the navicular and the tip of the navicular, and we know that that spring ligament lies right between them. Sometimes you can actually feel that spring ligament, and in David I can feel that ligament right here. So our injections then in this area will be aimed at these particular areas. The angle of our injection to do the inferior border of the malleolus is superiorly. And again, we have to imagine as we go the angle that we're doing on the bone. In other words, coming upward and in so that we're going to hit bone as we do the injections all the way around the malleolus, up, and we have to change our needle angle to hit the particular portions of the ligaments that we wish to hit. We then focus on the other areas that we have marked, and again, often noting that there are tiny areas of bony prominence where the tenderness is that we will be able to hit with our needle. Coming around, we don't worry much about the nerve and artery in this area because we're on bone below the nerve and artery, and so we really don't have a problem with aspirating or needing to aspirate in this area. Again, I would point out that we need to find these little bony prominences that are tender, and once you find it with your finger, just slide your finger a little bit to the side and go right into that bony prominence and do a tiny injection in this area. These are not large areas, so the injections can be 1/4 to 1/2 cc of your prolotherapy solution. We then move our attention to the spring ligament, coming again from the sustentaculum tali, little prominent bump, up to the navicular. We want to inject both ends of that on the navicular and on the sustentaculum tali. Again, in our model, looking at coming to the sustentaculum tali here, and then moving our needle up to the other end onto the navicular here. We then wish to drop our needle in deep into the ligaments in the bottom of the foot, coming across underneath the arch of the foot to the cuboid bone, which is right across the foot. So we'll be going quite deeply with our needle and hitting the calcaneonavicular ligament and the cubonavicular ligament. We can see those underneath the foot right here and here that come across, and as part of the interior part, here's the outer part of the spring ligament, and these are the interior parts of the spring ligament deep in the foot. We need to be careful as we enter this not to hit the plantar nerve, which can run down here. So we want to keep our needle aimed a little bit upward, walking in across to the cuboid bone, across the underside of the foot. So with our injection in the foot itself, we're coming between those two prominences, and you can place your fingers on them. And with our needle aimed a little bit in the dorsal direction rather than the plantar direction, we come across the foot and hit the bone, and then redirect our needle going backwards and forwards to hit the other areas of the calcaneal navicular ligament and the cuboid navicular ligament in this area. We're now in the anterior part of the ankle, and we have the anterior tibio-talar ligament, the anterior part of it coming down like this. And when we look at our model, it's this portion of that tibio-talar ligament right here. And so we can come in with our needle directly onto the talus. Sometimes this is a very tender portion deep in near the talar dome, and we can see that injection in our model again with the tibio-talar portion of the deltoid ligament right here. We're now looking at the lateral part of the ankle, and again, carefully drawing our anatomy with the lateral malleolus, the bottom of the fibula, the lateral ligaments, the posterior talofibular ligament coming right here, and we can feel the little bump on the talus coming over to the fibula, the calcaneal fibular ligament coming down like this. We can again feel bumps on the calcaneus where this attaches, and the anterior talofibular ligament that's going to be right in this area. We can see these on our model. Posteriorly, the talofibular ligament here. Inferiorly, the calcaneal fibular ligament here. And anteriorly, the anterior talofibular ligament coming across from the fibula to the talus. Another important structure in this area is the sinus tarsi. The sinus tarsi is surrounded by ligaments, as well as having ligaments inside it. And we can palpate the sinus tarsi in this area. This is best done by inverting the foot, and that actually opens up the opening into the sinus tarsi. We can push our finger directly into it, and this is where our injection will go as well when we come to the injection portion. The sinus tarsi we can see quite clearly on the model right here, and inside the sinus tarsi is an interosseous ligament, the talo from the talus to the calcaneus ligament, deep in here. This also is surrounded by the anterior talofibular ligament right here, and the calcaneal navicular ligament right here, so that the area all around the sinus tarsi can be quite tender and needs to be injected, these attachments all around the sinus tarsi as well as into the sinus tarsi itself. Looking at our angles of injections, again, we can carefully palpate, feel small prominences of bones, and come in directly onto those prominences, injecting small amounts of solution as we go, catching both ends of our ligament, although more often one finds that the distal ends are more tender than the proximal ends in this area. And again, the tibial calcaneal ligament. And when we do the sinus tarsi, we can invert the foot a bit and put our finger right in the joint space, go directly into that. We can use an 1.5-inch needle or a 2-inch needle, and we can either deposit 3 to 5 cc's of our preferred solution into the area, or we can walk around and do the interosseous talocalcaneal ligament inside it on bone. Generally, I just inject into the area and use 3 cc's of solution. When the joint begins to expand, people will feel pressure and discomfort, and that's a time to stop with your injection at that point. We now move up to the ligaments connecting the tibia and fibula, and we know that our tibia comes up like this. The tib-fib ligament we can feel right here, right there, and we will palpate that, again feeling for tenderness in it. It's right across there. And then we can move up into the interosseous space where there's a band of fiber across the interosseous area and inject on the tibia and on the fibula as well. Generally, it's not up very far, but down in the lower portion of the interosseous membrane, we need to do our injections. So thinking about our needle angles, we're coming into the fibula and then onto the tibia for the tib-fib ligament, and then moving up coming onto the fibula and over onto the tibia, walking up a bit in that interosseous membrane that connects the two bones. Looking at our model, we're looking here at the tib-fib ligament. So we're injecting on the prominence of the fibula and the distal tibia, coming into that area, and then the interosseous area shown here on the fibula and the tibia. One final injection in the ankle itself is the intra-articular injection, and this is fairly easy to accomplish if we come directly under the fibula. And so we feel the bottom of the fibula, and then our needle comes directly in under that, directly into the ankle joint for an intra-articular injection. We would be using 25% dextrose mixed with some lidocaine for this injection. We can see on our model that we're going right through the lateral part of the fibulo-calcaneal ligament and coming in underneath that bone under the fibula that puts us right into the ankle joint. Other areas of the foot may be tender, but much less often. We may have tenderness in the attachments of the cuboid, which we can palpate around, and again, careful palpation with one finger so that we don't confuse the patient about where we are. We'll find tender areas of attachments of the ligament to the metatarsal in that area. The metatarsals may have tenderness at the bases of the metatarsals, and we can feel those as we move the foot back and forth. There's the base of that metatarsal, and we can feel the space moving under our fingers. So again, this is careful palpation, and this is a less frequent area of pain. We then move down to the heads of the metatarsals and the so-called Morton's neuroma in the interosseous area between usually the second and third and fourth toes. These areas on the skeleton are shown just proximal to the heads of the metatarsals. And if you palpate in this area, just behind the head of the metatarsal right there, right in there, people will say, "That's my pain, that hurts."